Le GRISE a pour mission de produire des connaissances scientifiques utiles sur tout le continuum du développement des enfants, donc de l'enfance, en passant par l'adolescence jusqu'à la période du jeune adulte, en se préoccupant particulièrement des jeunes qui sont à risque de présenter des difficultés d'adaptation ou qui en présentent. Le GRISE rassemble 30 membres chercheurs réguliers de l'Université de Sherbrooke, 15 membres associés, plus de... en fait, actuellement, on est à 90 membres étudiants, 6 membres chercheurs au postdoctorat. Le GRISE a aussi l'honneur d'abriter 4 chaires de recherche du Canada et 2 équipes de recherche financées par le FRQ-SC. Les personnes qui sont intéressées à mieux connaître le GRISE sont invitées à consulter notre site web à grise.ca. Merci. Alors, je suis heureuse de vous voir aujourd'hui assister en ligne ou en présence à cette deuxième conférence internationale organisée par le GRISE en collaboration avec la Chaire de recherche du Canada sur le vivre-ensemble, les médias numériques et les enfants, vision écosystémique, dont Caroline Fitzpatrick, membre du GRISE, est la titulaire. Cette conférence s'inscrit dans le thème fédérateur santé, promotion, prévention et approche de précision. Et nous tenons à remercier le thème pour les dîners gracieusement offerts aux personnes qui sont en présence. Je tiens aussi à remercier les professionnels qui ont facilité l'organisation de cet événement. Mylène Villeneuve-Cyr, comme toujours, coordonnatrice du GRISE, et Hélène Baudry, coordonnatrice du thème fédérateur santé. Alors, quelques aspects techniques. Merci. Bonjour. Merci de mettre vos cellulaires, s'il vous plaît, en mode silencieux. Et en terminant, nous savons que certaines personnes étudiantes ou qui enseignent devront nous quitter avant 13 heures pour assister à leurs activités. La conférence sera d'ailleurs enregistrée avec le consentement du Dr Asbridge. Donc, ne soyez pas gênés de quitter à ce moment. La rencontre, comme je vous le disais, est enregistrée. Et pour les autres, il y aura une période d'échange qui est prévue avec Dr Asbridge. Vous pourrez à ce moment-là vous exprimer en français ou en anglais. Une personne se chargera de traduire pour notre conférencier si vous vous exprimez en français. Alors, sans plus tarder, je cède la parole à la professeure Fitzpatrick pour qu'elle nous introduise son collègue Dr Asbridge et sa présentation. Bonne conférence et merci beaucoup à l'avance à Dr Asbridge.
Merci beaucoup, Geneviève. Donc, c'est mon immense plaisir de vous présenter le professeur Asbridge. Le docteur Asbridge est professeur au département de santé communautaire et d'épidémiologie, ainsi qu'au département de médecine d'urgence à l'Université Dalhousie en Nouvelle-Écosse. Ses travaux ont aidé à avancer l'état des connaissances sur la santé des populations, les addictions et la prévention de blessures et d'accidents de la route auprès des adolescents et des jeunes. Ces travaux ont été publiés dans les meilleures revues dans le domaine de la santé et incluent The British Medical Journal et JAMA. Il a aussi mérité de nombreux prix, dont le prix MAD Canada Professorship in Impaired Driving Research and Prevention, ainsi que la bourse salariée de nouveaux chercheurs de l'IRSC. Personnellement, je me considère chanceuse de le compter parmi mes mentors et mes collègues. Mark, I'm very happy to extend a warm welcome to you. Donc, je vous demanderai, s'il vous plaît, de m'accueillir dans l'accueil chaleureux du professeur Mark Asbridge.
That's mine. Oh, I got it. Yes, I can do it. Sorry. Oh, maybe not. It's not there anymore. Oh, sorry. Right.
Ça va comme ça? Is that okay?
Mm-hmm. Great. Bonjour. Je m'excuse, je ne parle pas français bien, donc je vais parler anglais. Thank you for allowing me to speak with you today. I just have a slight anecdote before I start. Many years ago when I was in university, I grew up in Ontario. The Ontario government wanted to encourage people to learn French. And I had poor French training in high school, so I wanted to learn. So there was a program to send us for a summer to Quebec. And you could choose from Montreal or Quebec City, which a lot of my friends wanted to do, but there's too much English and not enough French. So I wanted to go somewhere smaller. So I went to Trois Pistoles for the summer. So pretty much as east as you can go, maybe. I spent the summer there learning French, and there were various levels of French. And it was a great time. I loved the community. I had a wonderful family that I lived with. And at the end of the summer, they would offer you the opportunity to work in the community for 2 weeks, the last 2 weeks of the summer. And you could work in a job that would match your level of French. So I had some friends. So my friend Sally, she was excellent. Her French was beautiful. She had done so well over the summer. What can you do, Sally? We think that you would work very well in the restaurant. You could interact with the community. You could talk to people. You could take orders. That was great because your French was so good. And then my roommate, Philip, his French was not quite as good, but still much better than mine. And he got a job at the gas station. So he could, and it was one of the, not a self-serve, but the ones you fill up the tank, full service is the term. And then it came to me, and they said, Mark, you've worked really hard, but based on your level of French, we think a job best suited would be in the garderie, the nursery or the daycare. So that was my job, was to work with 3-year-olds and 2-year-olds, because that was the level of my French. So thus, I will not speak to you in French. I apologize. All right. So I thought I would just give you a little bit of context to what I'm going to talk about. This is sort of an overview of my research program, and I wanted to sort of align it with the work that's done here by GRISE and those of you, probably most of you attending. So I work in these broad areas. I've done most of my work in substance use, addiction, and mental health. I'm a sociologist by training, but I did a postdoc right after that. I'm a quantitative sociologist. I did a postdoc after in a hospital doing the Center for Addiction and Mental Health in Toronto, which is a research hospital. And then I came to Dalhousie into an epidemiology department. So I've had the sociology sort of beaten out of me over the last 20 years. But I still have a lens on a sociological lens, and I like to try to keep that as much as I can, though I'm not as much as I would like. So substance use, addiction, and mental health. I've also focused on injury prevention and then a lot on child and adolescent health. My dissertation, in fact, was based on, I was involved with my supervisor, and I went into every school, went to 31 high schools and to 12 youth shelters, and we collected surveys from 4,000 young people, 400 street youth and 3,600 school youth across 31 schools, looking at a range of issues that many of them would be of interest to you around cognitive well-being, scales on emotional support and social support and social determinants and things like that. So I've done a lot of work, and then over the years I've done a lot of work in school environments, collecting data in the Atlantic provinces and so on and so forth. But I often do most of my work in the sort of the intersection of this diagram, and so I would probably, if people, not that anybody knows who I am, but if you did know who I was, you probably know me for the work I do in impaired driving. I've done a lot of work in drinking and driving, and then in the last number of years with cannabis and driving, and that's sort of where I focus. But I like to have a policy and intervention and an evaluation perspective in the work that I do. So I do a lot of policy evaluation work. Do policies work as intended or not? What are the, the outcomes related to policies, the effectiveness of policy, and then what doesn't work? And I connect with government at various levels, as well as internationally, the WHO and so forth. So I like to have a sort of an applied element to the work, which I think very much fits in with what you're doing here. The other thing I would like to point out is I say this a lot. I know there are many students here. I work with students. We have a graduate program in our program, master's and PhD, and I work primarily with secondary data analysis. I do a little bit of primary collection, but I mostly work with secondary data. There is so much data available, and it's so poorly utilized. And that's whether it's data that's collected by researchers such as myself, or Statistics Canada, or data from hospitals, or from justice, the health data, education data, just a wealth of data. And I think we as researchers or budding researchers need to take stock of the data that's out there that we can use to our purposes and to answer the questions that we want. And I do employ mixed methods, but I'm largely quantitative, but I have done qualitative work in the past. And then the other thing I say, essential part of what I do is working with young scholars, highly qualified personnel, master's students, PhD students, postdocs. If you looked at my publications, pretty much, at least in the last 10 years, almost everything involves a student or a learner in some way, and I think that's an important part of what I do. So this is my first talk to an audience in years. It's very odd to be in a room talking to people, and with the hybrid actually of being online as well, which is very unique. So since the pandemic, I haven't been to a conference or given an invited talk or anything in many years. So I'm excited and slightly nervous about it at the same time. So what I want to talk specifically about today is this work that we've done, and Caroline has been involved in this as well, adolescent injury, substance use, and mental health, an exploration of rates, determinants, and comorbidities in Canadian survey data. This was supported by Parachute Canada and CIHR, the Canadian Institutes of Health Research. Parachute Canada is a more recently established NGO that deals with child and adolescent injury. It had older names, or it was a combination of three previous organizations. One of them was called Smart Risk. Another one would have been called Safe Kids Canada, and they merged together to have a more powerful role in injury prevention. And they worked with us on this work. And this work was, a lot of this work was done by three students that I worked with, Kathleen McNabb, Nathan Smith, and Alicia Robinson, who are all no longer with me. They're all in a better place, doing better things with better people, and that's great, and that's my goal. So I think I should, please correct me if I'm wrong, I'd like to acknowledge that the land on which we gather is the traditional and unceded territory of the Abenaki people. I think that's correct, and the Wabanaki Confederacy. So I don't have any conflicts of interest to declare. As I mentioned, this was funded from an operating grant from the Canadian Institutes of Health Research. I should actually point out, this was, the CIHR does this, has been doing it quite regularly, is operating grants for the use of secondary data, very specific grants that can attract. I don't know if most of you lean towards SSHRC or look at CIHR, but they have grants, $100,000 for 1 year to 1 to 2 years to look at secondary data, and this was one of these grants. And they're often sponsored by the Institute for Youth and Adolescents and Child and Adolescent Health. There was also support for this from Statistics Canada through the regional data centers of Canada, in which we have one at Dalhousie University. It's called the Atlantic Research Data Center. And we conducted this work with the knowledge stakeholder being Parachute Canada. They helped us to design and develop the question we were interested in, and the knowledge translation that occurred afterwards. So injuries to children and adolescents are a very common experience in Canada. And when we talk about injuries, we typically delineate between two groups of injuries broadly. These are intentional injuries and unintentional injuries because they have different mechanisms and they have different determinants. When we talk about intentional injuries, these are what are defined as injuries that are inflicted upon oneself or another person deliberately. And this is often in the form of interpersonal violence or self-harm. Unintentional injuries are sort of a broader category, and those we define them as sort of not without deliberate intent, essentially. And these are injuries that occur resulting from things like poor weather, from falls, sports-related injuries, or being hit by an object accidentally. And I put below that traffic-related injuries are a bit of a gray area. So having worked in the area of road safety and motor vehicle collisions and bicycle collisions, pedestrian, they get called accidents, and really in most cases they're not accidental, they're highly preventable. They've been caused, or the mechanism is by a choice or an action to drink and drive. That's not accidental. To speed, that's not accidental. So there truly are accidental traffic-related injuries, but in most cases I consider them to be more in the intentional side of things. But this is a gray area, and there's no general consensus on that. So the notion of studying injury in a similar fashion to how we might study diseases, and maybe infectious diseases, was first described by a physician, John Gordon, in the mid-19th century. He was a physician epidemiologist, and so quite a while ago. So his work investigated patterns of injury according to things like the age of the person, the place in which they lived, the time that the event occurred. And he used that to assist in promoting an understanding of the event of an injury and the fact that it's really it's a non-random event. It's a non-random occurrence. This was picked up, sorry, just one thing I want to do here. See, can I move this up? Up to the top, is that better? Or I can minimize it altogether? Yeah. Okay, perfect. Thank you, parfait. So this, William Haddon later expanded on this work by developing a conceptual model called Haddon's matrix. And this was a model for describing the origins of injury and the associated factors related to injury. So under this framework, variables relevant to the injury, the etiology of an injury, are measured as they relate to both the sort of something we call the epidemiologic triad, which is the host, the agent, which is the disease, and the environment. There's a relationship between these things, the individual, the environment that they're in, and the disease. It added to this by looking at the agent being, the host being human factors, and then dividing it into both the physical environment and the social environment. And Haddon added also a time event, so before the injury occurred, when the injury occurred, and after the injury occurred. So factors related to injury are then sort of tabulated within these cell components to provide sort of a sense of the different windows in which injuries occur, the things that might be related to that injury, and where the opportunities would exist to intervene to prevent that injury from occurring or to mitigate the harm from that injury. And so this model has helped to shift injury prevention efforts from changing individual behavior alone towards addressing both the individual, the agent, and the broader social, cultural, and physical environment that leads to the injury. So here I have an example. This is really just an example of a fall-related injury, and you can see that there are different factors identified in the matrix that you could consider, like the age of the person. So a person who's older has a higher risk of a fall, and also greater consequences from when they do fall versus a younger person. You can also consider the agent characteristics. So maybe the person was using alcohol at the time, which increases your propensity for an injury. And then the environment, maybe they were walking in an area that had an absence of a sidewalk, or some social cultural factor like they lived in a lower socioeconomic status neighborhood. So opportunities to prevent this particular injury event or the morbidity and mortality related to it can exist at these different stages and places, different times and places along the injury event, before, during, or after. And so this is just to give you a sense. And so when we look at injury, we often know much about the injury, but we don't know as much around the context of the injury itself. So hospitalization data has provided really valuable information on adolescent injury. So hospitalization data is when someone comes into the hospital, they may come into on their own, they may come into the emergency department, and if they become hospitalized, in other words, if they stay overnight in the hospital for one night, they are now considered a hospital as part of hospitalization data. You also have things like physician billing data, which is if you visit your primary care physician, that event is recorded as well. So these kinds of hospitalization or physician billing are valuable pieces of information for understanding adolescent injury rates. In fact, there's a national data set called the CHIRP data. I'm not going to pronounce the acronym, but it's the Children's Hospital injury data set. It is across Canada, a couple of hospitals in each province, and it collects injury data specifically for young people and looks at some of the contextual information associated with injury. So from these data, we know that unintentional injury, which I talked about, things like falls, et cetera, is a leading cause of death among Canadians younger than the age of 24. So that's kind of an unknown fact. People don't recognize that. And it represents about, depending on the year, between 26 and 40% of all deaths in this age group. Intentional injuries, the violence or self-harm related, also plays a significant role in morbidity and mortality among Canadian youth, with suicide representing the second leading cause of death from those aged 15 to 24, and homicide the fourth leading cause for this age group. In 2012, there was a total of 1,013 Canadians under the age of 24 who died as a result of unintentional injury. So that's in a single year. And the most common causes of mortality due to adolescent injury are motor vehicle traffic injuries and followed by drownings. In terms of injury-related hospitalization, the most common thing is falls, which accounted for about 44% of all childhood admissions to hospital between the years of 1994 and 2003. Falls we think of as a seniors thing, older adults as you age, but falls is the #1 cause of injury-related presentations for every age group in Canada, and young people included. I took my son to the hospital more than once for a fall-related injury because he's a moron. So, in a loving way, and he can't hear me, so. More recently, considerable attention has been directed towards things like traumatic brain injury, like concussions, which are unrecognized as a major public health problem in adolescents across Canada. I think in North America, there were just under 2 million people annually who sustain a concussion or more severe traumatic brain injury. So it's quite substantial. And previous studies have shown that patterns of injury tend to be actually fairly similar across provinces, though youth in the territories and in the north have at least in some of the administrative data, tend to suffer more from intentional injuries, and then in some of the provinces, it's more unintentional injuries. So there is some variation there. Sorry. So this is a graphic from Parachute Canada, the NGO I talked about, just to give you it's sort of a snapshot. And this is a report from almost 10 years ago, which is actually a sad thing that the most recent data from a national organization on like national rates is 10 years old. And it's looking at unintentional injuries for those 14 years of age and younger. And just to characterize it, there were 210 deaths related to unintentional injuries from 2003 to 2012. You know, over 16,000 hospitalizations. The the good news they're talking about is that if you look at the time trends, they're declining over these time periods, which is the good thing. Unintentional injuries related deaths were about half of them were from the road related injuries, and hospitalizations, falls were the big thing. So road related injuries, $380 million, 1.2 billion for injuries from falls, and about 2.3 billion per year in adolescent injuries overall in Canada. So this is a substantial burden. And so when you think about Canadian adolescents, they die from injuries more than all other diseases combined. Unfortunately, injuries are not widely viewed as a serious public health concern. Instead, society holds this norm, or there's this cultural view that that mischaracterize injuries as accidents, as random events that are unavoidable, and that's simply not the case. You know, we know that the classification, you have these official classifications of unintentional and intentional injuries, and it suggests that, you know, human error is, you know, not necessarily the big issue, but human error plays a lot of the role in sustaining injury, and injury epidemiology clearly shows that most injuries are preventable and they're not accidents and they're not chance events. And that when you delve into it, there are important things like a social gradient, a social class gradient to injury, and that most injuries we could do something about if we knew more to do in advance. And they're generally understudied. So most injury research relies on hospitalization data, something like that Canadian hospital injury reporting data I talked about, or things like the discharge abstract database, administrative databases you can get from the Canadian Institutes of Health Information. So this ignores injuries that are not seen by healthcare professionals, because healthcare professionals might see the more severe injuries. So it ignores less serious injuries, or injuries that the person did not report to hospital, things like abuse, for instance. So the majority of injuries are not seen by healthcare professionals, and we also lack contextual and demographic information needed to identify populations with high injury burdens. So I like to think about a metaphor when talking about injury. There's two metaphors I'll draw on. Well, one main one, which is the iceberg metaphor, and I'm sure you've seen this used. It's used for various things. And the iceberg metaphor for disease really is that, you know, like an iceberg, most of the iceberg is under the water and you don't see it. And in this case, when we think about diseases, you know, we see what's above the water, the top of the iceberg. That's what presents to the hospital. That's what sees the physician. That's what gets a clinical designation or a clinical code. And so it tends to be the serious injuries or the major injuries, or the serious disease, not the less serious disease. And so what we also know is that most of the injury that occurs, we don't see. So there's more that we don't see than what we do see. And so in some ways, you know, we have to get away from only looking at what's above the water and getting a better sense of the full iceberg. And so really that's what the rest of my talk is going to focus on. So when you think about injuries as well, there's this thing called the pyramid. It can be used for other things as well, but you know what you have is, when you have all injury, if you think of the pyramid as all the injury that occurs, you know, the deaths are at the top, they're the fewest, but you know, you see injuries resulting in hospitalizations, you see injuries resulting in ambulatory or emergency treatment, and you maybe see injuries that result from treatment in a primary care setting with your GP. And then there's the rest of the injury, which is the largest portion of injury at the bottom. So they often call this the dark figure of injury, or the dark figure of disease, the unknown level of disease. So despite then the identified health and economic costs associated with injury, the 2.3 billion I was talking about, current estimates capture only a small portion of all the injuries that occur. So we're only counting those 2.3 billion as only the injuries above the iceberg, above the water, the iceberg. And much of the injury that is because it's coming from those official data sets, you know, doesn't look at the less serious injuries. Now, of course, the less serious injury is going to cost less, but there are serious injuries that go underreported for various reasons, you can imagine. So you have this hidden adolescent injury in Canada, and we need to understand more about it. And so our project is an attempt to understand a little bit more about that. And while administrative data are excellent sources of injury data, hospital data are very precise. They're objective indicators rather than subjective indicators. So they have benefits, and they provide valuable information on healthcare service use, and they can inform to some degree that way. But they are, I would say from a methodological standpoint, they provide biased estimates of injury rates because they don't look at the less serious injury or unreported injury. They don't explore the social determinants of injury and the social determinants of health as related to injury. And this is an important piece. Hospitalization data just has the diagnosis, what happened in the hospital, the basic information about you as an individual, and doesn't provide any context to the injury, doesn't record any of the other broader sociodemographic, important sociodemographic, around income and poverty, around the mental health or substance use or other important indicators that have strong associations with injury. So they don't assess comorbidities. And then, of course, there's inconsistent reporting of data across provinces, and that's an issue as well. We have, for instance, in the province of Nova Scotia, which has a population under 1 million people, it uses emergency departments. There are 3 different computer systems to collect data on visiting the emergency department, depending on where you live. Absolutely absurd. Like, that's absolutely absurd. So, so you don't capture the same things. I mean, one hospital uses the official codes, which are ICD. I don't know if you've heard International Classification of Disease Codes, and other hospitals, they make up their own codes. So how do you compare? You can't compare, it's impossible. The current study really sought to address these limitations, to attempt anyways, to help inform national stakeholder action on injury prevention and control. And the current research, what I'm going to talk about, estimates the rates of total intentional and unintentional injury in Canada and each province for adolescents between the ages of 11 and 19 years. And it draws on self-report data that includes important contextual information and includes less severe and more common injuries than those that you would find in hospital or administrative data. So we're hoping, in a sense, that we're providing a bit more of a fuller picture of the full burden of injury and the characteristics associated with injury. And determining the prevalence and correlates of self-reported injuries among Canadian adolescents is really an essential thing to identify vulnerable groups and vulnerable populations or vulnerable regions that may benefit from interventions. So the methods here, not overly complicated. We're really looking at just prevalence estimates. It's not the most exciting, so I'm going to provide some prevalence estimates for injuries that were calculated. We applied sample weights for the data and statistical associations. We did do adjusted logistic regression to look at significant differences between injury groups, but I'm not going to spend too much time. I'm just going to talk very descriptively about the data. Sorry, 1 second here. So this is to give you a sense. We used 6 data sets. The work draws on 6 data sets that measured self-reported injuries among youth and captured demographic, mental health, and substance use data. And we chose the most recent waves of the data that were available at the time that we did the analysis. So that ranged up to 2017 when we did the analysis. I'll talk a little bit about each of these surveys. So the main one that we looked at nationally in each province was the Canadian Community Health Survey. Stats Canada collects this nationally. 130,000 people or it's about 60,000 people a year, 65,000 people a year across Canada are asked information. It's a general health survey. It includes some questions on injury, but lots of social determinants. We also included some smaller surveys. The other national survey was the Health Behavior Survey of School-Age Children. This is a WHO survey. It's done by a team at Queen's University. It is collected at each province, but they don't provide the provincial data. They only provide you national data. And it asks a different set of questions around injury, but some of the same determinants. The other data sets are specific to provinces. We had the Ontario Student Drug Use and Health Survey, which is an ongoing student survey that's been going on in Ontario since 1977. It's the Student Drug Use and Health Survey. They added health more recently, so it includes some questions, but very limited on injury. We had, through Caroline, the benefit of looking at the Quebec longitudinal study of child development for the 3 waves of 2011, 13, and 15. So this includes questions, some questions on injury as well, and has the only data set with longitudinal piece to it. And then the other data set from BC is the British Columbia Adolescent Health Survey done by the McCreary Institute. So this is done every 4 years, about 50,000 BC adolescents. Very vague questions on injury, but lots of good social determinants questions. And then the Student Drug Use Survey of the Atlantic Provinces from 2012, which is a student survey that I did, and it was done in New Brunswick and Newfoundland and Nova Scotia. And again, it's mostly a student drug use survey, but it does include a couple of questions on injury, but it has other good determinants. So we put together as best we could the different kinds of injury questions as intentional, unintentional, total injury. They were not consistent questions across the surveys, but we pieced them together in a way that seemed reasonable. So we have, because the injuries, we followed the delineation, the typical of intentional injuries and unintentional injuries, and the different determinants. We sort of collapsed them based on, the falls and versus self-harm or violence, falls versus, poisonings, drownings, things like that. So again, intentional, those afflicted upon oneself or another person deliberately, and unintentional, those without deliberate intent or harm. So we matched the questions from the data sets based on, as best we could, based on those categories. And then we also summed up what we called total injury. So it was any of the injuries, whether it was unintentional or intentional, or in some cases, we couldn't put in the injury as either intentional or unintentional. It was too unclear. So it was included in total injury, but not in an individual category of injury. And then we had 3 groups of exposure or independent variables. We had sociodemographic, mental health, and substance use. And these were selected because they're commonly included in population health surveys. These were generally consistently included in surveys, the different surveys, and they're also have known to be associated with injury rates. So we had sociodemographic measures like age, respondent sex, income, or socioeconomic status, which is oft we tried to collapse into terciles, high, medium, low, and whether they were employed in the last year. And then we had mental health. So we had questions on the presence of anxiety or mood disorders. Some surveys the question would be something like, has a physician ever diagnosed you with a mood disorder like depression, et cetera? Or other cases, it was a self-reported, like, have you ever felt depressed or used the CESD depression scale or something along those lines? So again, presence or absence of depression measured sort of in a very sort of blunt way based on combining the different surveys together. And then substance use. So in most cases, past year substance use, whether they'd used alcohol, whether they used tobacco or cannabis. We had some surveys that included other illicit drugs, but prevalences for those are actually quite low. So we just focused on alcohol, tobacco, cannabis. And looking at sex-specific thresholds for binge drinking. So traditionally that was 4+ drinks in a single setting for females, 5+ drinks in a single sitting, for males for binge drinking. So those are consistent questions asked across the country. But they are still different in some cases. And so this bears out in the data. So I want to present, I'm going to give you some overviews of the national picture. And the national picture comes from the 2 surveys, the Canadian Community Health Survey and some of the data from the Health Behavior and School-Age Children Survey. And then I'm just going to walk through each of the provinces very quickly because it's not the most exciting data. It really is. I mean, it's either listening to me or watching paint dry. You can decide. And then that's from the individual province data comes from the CCHS or some of these individual school surveys. And in some cases, we can't report things because the data, there's rules in Statistics Canada about the size of the number of cases or the cell size or the sample size for an outcome. And if it's under a certain threshold, we can't report it. So I apologize for that. This was unforeseen. So these are just prevalence estimates, and I'll indicate if things are significantly different, which is at a very modest 0.05 level. Basically, the national data sets show that injuries are common, obviously, among adolescents. The Canadian Community Health Survey found about 31% had experienced an injury in the last year. And the health behavior of school-age children found over 50% had experienced an injury in the last year. So different questions in the different data sets, but still showing the substantial burden. And then the majority in both cases you can see are unintentional injuries. Intentional injuries are much smaller, so 3% and 1% depending on the survey. And that's not necessarily out of line with from other work. But both data sets provided very similar estimates for these unintentional injuries, about 26% experiencing an intentional injury. So that was promising to see that consistency across two very different data sets. So the CCHS is asked of the entire population, and we pulled out just those who are 12 to 19 years of age, just to give you some context. So when you get from 60,000 and then you pick out those who are 12 to 19, you're getting a smaller proportion, and then you divide that by provinces, you're talking about some very small samples in certain places. Now, age and socioeconomic status in the national data didn't really have a clear pattern with injury prevalence, though when I look at some of the provincial data, there are some provinces where SES and age seem to matter. Females had significantly lower injury rates generally at the national level, but you'll see when I talk about the provincial level, there's some provinces where females had higher injury rates. Employment status was only measured in the Canadian Community Health Survey, but there was some suggestion that that employment status was associated with a higher rate of injury, and that's a pretty common finding in other work. Having anxiety and mood disorders strongly related to injury rates, higher injury rates, and of course substance use, any substance use, tobacco, alcohol, or cannabis was associated with significantly higher rates of injury at the national level. Now, the one exception is cannabis in one survey was marginally significant, and in the CCHS, it was maybe not associated significantly, or was on the border of being significant, which is actually interesting in the context of cannabis legalization that's gone on, that, you know, there's the assumptions about the various harms that have been produced by cannabis. And I would say, having been involved in some of the national evaluations of cannabis, the impact of cannabis, it's been really unremarkable. The concern that was in advance really did not play out in ways that they thought it would. And that relates to the areas that I work in terms of driving under the influence. Has been, you know, not as substantial change, but other cannabis related indicators. And so maybe we were worrying more than we needed to. I know that's being recorded, but I'll go on a limb. All right, so I'm quickly going to go through some of the provinces. So just to show you, Newfoundland and Labrador, total and unintentional injury rates are slightly higher than the national average in Newfoundland. And if you compare provincial versus national injury rates, these are based really on the Canadian Community Health Survey, because that's the only survey that's across Canada. Unintentional injuries weren't captured by one of the surveys, and so there's no comparison between the two surveys. But females had more injuries, and higher SES individuals had fewer injuries. So for Newfoundland is different than the national average, where females had higher rates compared to the national average, which was lower rates. And again, you'll find this consistently across provinces, that all the mental health and substance use indicators showed a significant increased odds of injury among individuals. So anxiety, depression, alcohol, tobacco, cannabis. Prince Edward Island, all we had was the CCHS data, and we had a very small sample, but The total and unintentional injuries were less common than the national average, about 30% overall and 26%. And the only relevant indicator was higher socioeconomic status was linked to injury. So that's a common one. It seems counterintuitive, but people of adolescents of higher socioeconomic status tend to do things like more sports, for instance, than they're more mobile, they engage in more social events than people of lower socioeconomic status. And so they're exposed to the injury events in ways more often than those of lower SES. So it's a different context or nature of injury. Nova Scotia, where I'm from, the total injury rate is the lowest in the country, and the unintentional injury rate is lower than the national average. There's a greater discrepancy in the association between the different determinants in injury in Nova Scotia than in other jurisdictions. So there was an opposite effect with age and socioeconomic status. So here in Nova Scotia, lower SES was linked to injury. And female people with mood disorders and those who use tobacco, alcohol, and cannabis, and those who binge drink had higher injury rates, as you would anticipate. New Brunswick, total and unintentional injury rates were lower than the national average, and then mental health and substance use again was associated with injury, and then being in the highest income was associated with fewer injuries. So again, you can see the lack of consistency in these associations across jurisdictions, which is unfortunate. And in Quebec, so Quebec had the lowest rate of unintentional injury in the country, and this is from the CCHS data, and total injury is also below average. Adolescents in Quebec who are employed, those who consumed alcohol or cannabis, or those who partook in binge drinking had significantly higher injury rates, very consistent. And then in Quebec, unlike Nova Scotia and Newfoundland, females had lower injury rates. And unlike most jurisdictions, those with anxiety disorders had a significantly lower rate of total and unintentional injury if we drew on the QLSCD data. And that was a little different than the trends from the other student surveys. Because the QLSCD is the only longitudinal data set in this study, I just thought I'd give you a little trend chart here. Just shows the trend in unintentional, intentional, and total injuries. The point estimates are here, 95% confidence intervals for the years 2011, 13, and 15. And as you can see, this is when they were 12, 13, 14, 15, 16, 17, and the rates are really fairly stable. Of course, there's substantially more unintentional injuries than intentional injuries. So not a lot of change in the point estimates. So they weren't significant, but I just wanted to show you that it's nice to have longitudinal data. In Ontario, total and unintentional injury is slightly higher than the national average, and the prevalence of intentional injury is the same as the national rate. So employed youth have a higher rate of injury in all the data sets in Ontario as well. So again, that employed or higher SES, and then it's consistent with other places, mental health, substance use, were all connected with injury rates at a very significant association. There's actually a bit of a dose-response relationship too between socioeconomic status and in a dose-response manner. So as you went up the socioeconomic status, there was a negative relationship, reduced injury. But that actually flips whether it's intentional versus unintentional injury. So higher socioeconomic status seemed to be connected with unintentional injuries, whereas for higher people, but poorer socioeconomic status was linked to intentional injuries. So that inverse relationship. And that seems to make sense in some ways intuitively. Last couple of provinces, total injury in Manitoba was lower than the national average. There was really actually no significant associations with demographic, social, and mental health variables. We only had the CCHS for Manitoba and same for Saskatchewan, but alcohol consumption was associated with higher rates again, and binge drinking even higher. Saskatchewan was very interesting. Saskatchewan had the highest total injury rate in the country by far. It was about 10% greater than the national average, about 9% greater than Newfoundland and Labrador, which was the second highest. And similarly, for unintentional injuries, it was about 9.9% greater than the national average and about 8.5% greater than Alberta, which was the second-rated province. But there were few significant associations with key determinants, other than that older youth tended to have higher odds of sustaining an unintentional injury. We tried to look into this. We tried to figure out why is this the case, and there was some suggestion that there's a lot more of sort of in Saskatchewan. There's a lot of young people who get involved in sort of farming is very prominent in Saskatchewan, and that there were more youth that get involved in family farms, and a lot of the injuries were related to farming events, for instance. And that seemed to be an because the higher proportion of the population is engaged in farming. That was one, some triangulation of information from other researchers that we came across. All right. And Alberta, total injury was slightly higher, as well as unintentional injury than the national average. Not many associations with the key determinants. But though females did have lower injury rates, and employed people had higher injury rates. Finally, British Columbia, slightly lower injury rates than the national average with respect to the Canadian Community Health Survey, but there was inconsistent associations with age and sex and SES as well, though employment was associated with higher injury rate again, and mental health and substance use was positively associated as well. We also included the BC Adolescent Health Survey. It's not very useful. Ultimately, they had a very general question on injury that was very broad, and so they came off with a substantial 51% injury rate, and the question was almost probably, we included it, but it's probably not a usable question, not a valid question of injury. And it often included some of the injury questions were lifetime exposure versus past year exposure. So it's very hard to include them all. They're not really measuring the same thing. Just to sort of summarize comparison across Canada, just using the Canadian Community Health Survey, because that was the consistent across Canada, you can see the injury estimates. Total injury rates range from 28% in Nova Scotia to 41% in Saskatchewan. Unintentional injuries accounted for about 80 to 88% of total injuries. And intentional injuries were so rare that estimates were only published for a few provinces and at the national level due to these low counts. Don't pay attention to this. This is, yeah, I'll just talk about it. This is so for anybody giving a presentation, don't do this. This is a terrible idea. Never do this. Don't follow me. I'm not a good example. Never put a chart like this. So a student of mine pulled some data and put some slides and sent it to me, and anyways, don't do this. So this is the total intentional and unintentional injury rate at the national and provincial level from the 6 individual data sets. And overall, the data show most injuries sustained by adolescents are unintentional, which is the same as the Canadian Community Health Survey. And it also shows, unfortunately, that estimates vary greatly by the data sets. And so the differences between the values within the same cell sometimes are different between, like there's greater variation within provinces than between provinces when you compared like the Ontario student data with the CCHS within Ontario was greater variation there than comparing 2 different provinces. So it's a lot of inconsistency. And it's really due to the lack of there's unharmonized nature of the data sets and the fact that they use very different definitions and are probably measuring some different phenomena. But again, we collapsed them as best we could. So there is just heterogeneity. But from the CCHS, which is the same data, some of those patterns are relevant because they are the same questions asked the same way across the provinces to the same age groups. All right, so just to end off, just to say there's, what are the strengths? We use population generalizable self-reported data to examine what I call the hidden figure of injury. Most injuries are not lethal or treated in hospitals, so administrative data sets miss a lot of this. Also, these data sets offer a more fulsome picture of key demographic, SES, mental health, and substance use related measures, which don't get captured in hospitalization data. And so we don't know how these determinants relate. Of course, the limitation is that this is a small sample sizes for some of the data sets within some provinces, so we're underpowered and we're prevented from examining certain questions in more depth. And we can't present injury rates in some jurisdictions, and it's hard to look at causal associations as well. Injury rates vary greatly by data sets because concepts are operationalized differently in many cases. And this is why we had to use the CCHS mostly in the comparison. The other 5 data sets had lots of great contextual information, lots of great information on determinants, but there were small sample sizes and they're varied in the kinds of questions that were asked, so thus the inconsistency. So, injuries sustained by adolescents in Canada represent a costly public health issue. Much of the limited research in this area uses administrative data, which underestimates injury prevalence by ignoring injuries that are not treated by the healthcare system. And so self-report data provides really good population estimates when done well, and includes important contextual information so that we can understand injury correlates and we can understand injury burden. And most injuries were unintentional, and we found no clear regional trends evident other than what we saw in Saskatchewan. None of the social determinants, i.e. age, sex, SES, and employment were consistently associated with injury, but we saw some interesting things with related to higher SES and employment being linked to injury in some cases, and in some provinces, females having higher injury rates than males. However, anxiety and mood disorders were strongly correlated with injury, and substance use indicators, all of them were strongly correlated across data sets. So those are consistent findings and gives us a place to work with. Injury prevention and interventions aimed at reducing alcohol consumption, particularly binge drinking, may be effective in reducing adolescent injury across Canada. And I don't know if any of you have heard about the new low-risk drinking guidelines. I'm not going to ask you if you like them or not because I'm one of the expert panel members on it. But it's shifted. So originally, the low-risk guidelines for drinking were 10 drinks for women in a week, 15 drinks for men. Now it's 6 drinks. And the single sitting used to be the same 5 and 4 drinks in a single sitting. And now it's sort of 2 drinks in a single sitting or more, represents an elevation of risk. The new guidelines or guidance is really just meant to inform Canadians. It's not meant to preach or predict or tell you what to do. It's just to give you the evidence to work with, and you can make your own informed choices. But I would say consistent to what I'm seeing here around, injury and particularly acute injuries, alcohol plays a strong role in it, is one of the reasons why the guidelines are the way they are. Longitudinal data from Quebec shows no significant change in injury rates over the period of four-year period of time, and that was interesting. And also the 2 national data sets find nearly identical rates of unintentional injuries. And those total rates range from 20% to 41% in Saskatchewan, with an average of 31% nationally. So more than 4 out of 10 adolescents in Saskatchewan had an injury, which is really kind of concerning, and given how high it was. And so I think this work complements previous research that Saskatchewan has a uniquely high hospitalization rate for adolescents. This is supported from actual administrative data. So now we have self-report data and administrative data finding the same thing. But on the downside is we weren't able to pull out key determinants that were consistently related for that reason. So I think there's greater surveillance and maybe a different methodological approach is required to try and understand why this is the case. So the students that I worked with, they wanted to publish the Canadian Community and Health Survey, just the national data. And so they published the national data in the Journal of Health Promotion and Chronic Diseases Prevention in Canada. So I was really happy that they wanted to do that. And so one question I just want to end off is, where do we go from here? It's a hard question to answer. I think one thing we could do is have better tools for assessing injury, self-reported injury, maybe more consistent tools. This is one example. It's a tool that came out of the United States. It was actually then developed in Australia, and we used it once here in Canada. It's called the Adolescent Injury Checklist, and it asks about very specific aspects of whether you were injured and whether you were treated, how severe it was, and whether you used alcohol or drugs at the time of the injury. And it asks very specific questions so you can more neatly fit them into the intentional and unintentional categories. There's many more. There's actually 22 or so questions. It either in the past 6 months or the past 3 months, it tries to get a more precise indicator. So yeah, we've used it here. It was developed in the US and then it was taken to Australia. The Australian version, then the language was changed because in some of the things that the language is quite different about the types of injuries that are experienced in Australia. And then we moved it back to Canada and changed it there, you know, introducing snow related stuff as well, which is not part of the Australian, you know, so you can tailor it and make it useful for you. But I think something like this that could be used consistently across Canada would give us a more fulsome and better picture of what's going on from a self-report perspective. I think we also think about where do we go? I would say, you know, we need to develop maybe look to develop provincial or national injury prevention strategies. We develop strategies nationally for all sorts of things, but then when I tell you that injury is for this population is more combined than all other diseases for this age group, and we still don't have a strategy, a national injury strategy, I think that's a direction we could go. We need better data collection, particularly in the territories and in the north. They're underrepresented in both self-report and administrative data. And some of the evidence that is available suggests that injury rates are higher in the north. And finally, we need to do better at data linkage. So linking the health administrative data from hospitals with non-administrative data. This is being done. So this Canadian Community Health Survey, there's some panels of it that in the last few years has been linked to emergency department hospital visits, hospitalizations, etc. So you get the objective indicators from the hospital about what happened to the individual, and then you have all sorts of background determinants and contextual information about the lifestyle of the individual that you can bring together to get this really interesting picture. And I think we need to make use of that. So I will stop there, and I thank you for bearing with me as I went through this. So if you have any questions, I'm happy to answer them.